Hey YouTube, it's Marie from the Nurse Lounge, and today we have a viewer's choice video. So if you want to see what she wanted to know regarding OB nursing, or OB clinical, shall I say, you have to stay tuned. All right, so we're gonna go ahead and jump right in. If I sound different, I'm just getting over a cold that I have, and so that may be why I may be more nasally or whatever I got going on, but my cold is almost gone, or actually the cold part is gone. I still just have the cough, and anyway, we're gonna get through, and the congestion and stuff like that. We're gonna get through, but I wanted to share with you, I had a viewer who, she's also a follower on IG, who had some questions regarding OB clinicals and wanted to know my thoughts. She is currently in school herself, and so she says that she has OB clinicals coming up, and she only has 4 days of OB clinicals, and she kind of wanted to know what to expect during her rotation, and how to make the best of her time. So that's kind of two of her three questions. I'll get to the third question at the end. So to answer the first question, she says, what can she expect during OB clinicals? And so to answer that question, it really greatly depends on your school, your program. If you're in a 2-year program, for instance, you're going to have a different focus than a LPN program would have. And then even for a 4-year RN program, it's a slightly different focus from that. So I could only tell you, and I'm not sure what program she's in, but I can only tell you that I can give you my answer from the 2-year RN and 4-year RN. Well, really all three, but I can tell you what we do in clinical, because I do clinicals for OB, as a matter of fact. I still work in OB. I'm a clinical instructor for OB, so I can tell you what we do. This may not answer her question directly because I don't know what her program is going to do, but I can tell you again what I do when I do my clinicals with my students. So in my clinicals, we only have about 6 students per clinical group, which is great because it makes it small, and I'm able to divide my students accordingly to the areas they're going into. And in addition to that, provide more one-on-one time with my students when I have only 6 students compared to a larger number. I don't know what your program or her program, has or whatever it's going to be, but that is a good determinant about how much you can get done based on if your clinical instructor has to have 10 students and dividing his or her time amongst 10 students versus say 6 in my case. It's just much easier to do with a smaller number. So in my case, we rotate through three different departments. We rotate through postpartum, nursery, and labor and delivery. Now keep in mind, most hospitals have now converted to couplet care. So the postpartum and nursery component is together. So the nurses do what's called couplet care. So that means one nurse takes care of a mom and her baby or babies. So in that case, you may have a nurse that you may be paired with that will show you how to do assessments on moms and babies if that is the case. In our situation, we do not have couplet care, and that's kind of like a rarity nowadays. We do not have couplet care, so we have a nursery nurse, we have a postpartum nurse, and we have an L&D nurse. There are 3 different areas that my group rotates through. So basically what we do in labor and delivery, or what my students do or allow my students to do, they can do anything in L&D that's more like what a tech role would be. In our situation, due to hospital policy and to our School of Nursing's policies, they're not allowed to do a whole lot because it is a critical care area. Labor and delivery is a critical care area for OB. It's not critical care in the sense that they are sick. It's critical care in that you're caring for a mom and her baby. The baby's inside the mom still. So it's very complex and critical, shall I say. And so therefore, most of our students are only allowed to observe in that area. I don't know what your program is going to allow you to do, but they mostly observe. If they need blood pressures done, ours are pretty much automated where once we put the cuff on, it will just, do the blood pressure on its own every 15 minutes once we set it up for that. But let's say, for instance, our students wanted to kind of get more hands-on in that area. We allow them to, our school allows them to, if the mom says it's okay, the student's in there for the epidural to be inserted. The student is in there to see her birth her baby. We've had people where the parents have had, or the mom has not had anybody in terms of assistance. So we have our students who want to hold a leg back. So they want to be all up in there in it, so to speak, and hold a leg back and kind of see as the birthing process occurs. They're able to do that as well. We do not allow them to do anything invasive in L&D, meaning they cannot stick their hand in any orifice in L&D. So they can't stick it up in the vagina to see, you know, feel her cervix. They cannot do that in our school. Now, I don't know what your school allows, but in our school, the student cannot put their hand up in anything like that. Not in the rectum, not in the vaginal opening. They cannot put their hand anywhere like that. Once she has had her baby and they do the fundal exams, then the student is able to do the fundal exams with our school. So you will see, or at least what we see, is the moms giving birth. Obviously, we see the epidural being placed. Our students are allowed to go back for the C-sections, meaning they get, you know, they just scrub in and get suited up, so to speak, and then they go to the C-sections and attend those and observe and see how that goes. They cannot do anything in the OR, but they can observe. You know, they can just kind of stay out the way. We have some pretty good doctors who love to educate our students about what's going on, what they're cutting and what they're seeing. And, you know, they take the uterus out on top of, and place on top of the abdomen. They inspect, they clean. And once they, you know, see what's going on in there, they will then sew the uterus back up and then put it back in there. And then, you know, basically sew her back up. Students come out seeing all kinds of things. Some of them are amazed about what they see in labor and delivery. Some of them are like disgusted by it because maybe they don't care for L&D. It's a beautiful process no matter how the baby comes out, you know. Keep in mind, we see a lot of drug moms, so everything is not exactly how you think it would be in terms of the status quo, but we see a lot of different things. So that's basically what we do in L&D. In nursery, my students are allowed to do anything the nurse can do. So in nursery, shall I say, it's a little bit more hands-on. So we have them do head-to-toe assessments in nursery. They're allowed to give the vitamin K shots for our students. They're allowed to give the put the erythromycin ointment in the eyes for the baby. They can do that. We allow them to feed babies, obviously bottle feed babies. We allow them to bathe babies. We allow them to take babies back to the parents' room with a nurse who's going in that direction. We allow them to do pretty much almost everything. They attend circumcisions if the parents say it's okay. So we have a special consent for the circumcisions that specifically says our students allowed to observe. And if the parents say no, then the student cannot observe. But otherwise, students go observe circumcisions. They do the diaper checks. They do the feeding rounds. They do the own vital signs. We do vital signs, I think, twice a shift for babies. After the initial transition period, we do twice a shift. So we have our students do all those vital signs. We just have them really more hands-on in learning how to, you know, listen and, you know, listen to the baby's heartbeat and how fast it is. It's over 100. Babies need to be over 100. Adults are under 100. We have to remember that. And sometimes when we have people come from nursery to the floor with adults, they're like, oh my gosh, the heart rate's so low, because they're thinking like for babies. Babies' heart rates are above 100. Adults' heart rates, or our moms, are typically below 100. Sometimes they're around 110, 120 if they're dehydrated, but nothing for us to be too terribly concerned about. Just depends on the patient, what's going on with them. But that's nursery in a nutshell. And then for postpartum specifically, my students, I have them do everything. They're passing meds. They are doing IV type stuff with me. They're doing head-to-toe assessments. They are doing immunizations. During flu season, we give flu shots. We also give Tdap vaccines when if they need one. Obviously, flu shots are during flu season. We give MMR, so if they do not have their measles, not measles, the rubella, then we give them an MMR if they want one. And what else do we do? I think that's pretty much, and we chart. I have my students chart. So I'm at a facility in which they allow our students to chart on postpartum. So I actually will work with my students and we chart our assessments and we chart our vital signs and we chart the different things that we've done. My students are able to do discharge teaching, so I teach them what to teach the patient. So we talk about ahead of time, what should you be teaching your patients regarding different kinds of care, basically. So if they're going home, they have to document that. They have to document their I's and O's for the patient. I teach them how to clear their IV pumps. So when it comes to postpartum, I'm really hands-on with my students. We actually do everything. They actually come out feeling like they are a nurse. Now, some clinical instructors will put the student with a actual nurse. I don't do that personally because of the fact that I have to evaluate them. So that's just me. Anybody else wants to do what they want to do, that's fine. I personally do not believe in putting senior level students. I do have senior level students. Pairing them with nurses, because for one, the nurses cannot evaluate. I have to evaluate. So if I have to evaluate, that means I need to see what they're doing. Number two, the nurses sometimes take shortcuts and teaches them the wrong way. And then guess what the students are going to come out learning how to do? Things the wrong way. They will learn how to do shortcuts on their own, so we don't need help with that. So I really want my students to learn how to do things the correct way. I want them to learn their sterile technique. I want to make sure that they are, doing their head to toe assessments properly. And so that's the reason why I'm glad my groups are small, so I can actually just focus on doing my assessments with my students so that we can know and troubleshoot if we're doing something right or wrong. I ask them a lot of questions regarding, okay, how fast did you push this medication? We give IV morphine all the time. We give IV Phenergan all the time. We give IV Reglan or Zofran, both of them really. Phenergan, all of those, all the time. So I'm asking them questions in clinical. I'm saying, okay, how fast should we push this morphine? And they better not come back and tell me they don't know, because we have to do drug cards prior to even starting clinical. So they know we have certain medications we give all the time. And so they have drug cards that they're supposed to create prior to clinical. So they cannot come and tell me they don't know. And if they don't know, then I don't allow them to administer the medication until they find out. So if they don't want to be embarrassed, I tell them, go ahead and be finding out what your medications are before we go administer them, so you'll know exactly what it's for, the side effects. And I have them teach the patient that the side effects of these medications are this, that, and the other. This may or may not have answered her question, only because of the fact that I don't know what your clinical instructor would allow you to do or not to do. But basically, we are more hands-on. At least my program, we are very much hands-on. We get in there and do everything. If I have to have an IV taken out because maybe it's time for it to be taken out, my students do that. If it's time for a catheter to come out, my students do that. I teach my students how to check orders. So instead of a nurse saying, hey, it's time to take that catheter out, I'm like, we don't do what a nurse tells us to do. We do what the orders state to do. So I basically take them to the orders and log in and show them, okay, we got to take the catheter out. We got to take the dressing off. We got to do this and the other. We don't do things because a nurse told us to do them. We do them because there's order sets for them. So I teach them and show them how to go about looking up their own orders so they'll know the order of how we do things, not that we do things just because somebody says to do them. So basically, I personally feel that when I have my students, they may hate me. And I'm okay with them hating me because of the fact that they are being pushed to work harder than they ever had to work. But I always tell them, you're going to graduate within a year. You need to come out knowing how to do something besides observe and shadow. Now, I know I said that they shadow or observe in labor and delivery. That's something different anyway because of the fact that it's such a specialty area that you will get training in that area if you ever decide to go into labor and delivery. But as in general, when it comes to postpartum, which if you watched any of my videos, you know I call postpartum a specialized med-surg. So if it's a specialized med-surg, because that's basically what it is, you should be able to have a little bit more hands-on experience. You should bring everything that you've learned thus far regarding patient care, regarding blood pressures, if it's high, if it's low, what you should do. And my students have to troubleshoot all that. And they have never been forced to do that before. They've never been forced to critically think until they get to me. And unfortunately for them, when they get to me, they hate it because, like, what do you mean I have to critically think? That's what we do in nursing. So, if you're going to be a nurse, you're going to have to know how to do this and do this very, very well. Otherwise, you will kill your patient. And once you kill your patient, you probably won't have a license. So you don't have to worry about it no more. But that's kind of what I tell them. So That's basically all we do in clinical. I don't know, again, what your program is going to allow you to do. Every program is different. Some programs allow you to start IVs. Some programs allow you to take things out. Some programs don't allow you to do anything but observe. So it just depends on the nature of your program and what you can and cannot do. But for me, we do it all. My students come out feeling like, at least for those 4 days, because they have 4 days as well on my rotation. At least for those 4 days, they come out feeling like they are, I won't say a nurse, but they feel like more nurse-like, because they've not been shadowing. They have been doing themselves. They've had to think about things. I'm like, should we call the doctor or should we not call the doctor? They've come to me with temperatures of 97, I think it was. One student came to me with a temperature of a 97. So I was like, well, what do you want to do about that? They said, I think we should call the doctor. I said, well, based on what? Based on what's normal. I said, oh, so what's normal? And of course they're going to say 98.6. Well, I said, so what I did was I went and got a thermometer, and with the probes, and I took all the students, I think it was about 3 of us, including myself, it was 4, took all of our temperatures, and I wrote them all down. And none of us were 98.6. Some of us were 99. Some of us were 96. Some of us were 97 point whatever it is. And so I said, oh, okay, so since we need to call the doctor for this patient, I think we all probably need to go to the ER because we are all not normal. So that was her way of learning that, you know what, we have to look at patients' trends. We have to know this person's 97.6. There are parameters to temperatures here. She's not sick. The doctor says, do not call me unless it's above this or below that. It didn't fit the range. We're not calling a doctor. Those are kinds of things that we have to learn how to do in clinical. You know, you get caught up on these numbers and these parameters and things like that. Check your orders. Everybody's not a 98.6. Everybody's not a 120/80. Everybody is not a, 12 to 20 in terms of respirations. Everybody is not like that. Go check their trends. Once you check their trends, then determine, well, should we make another move? If you're still concerned, then go talk to your clinical instructor about it. And then, you all can make a decision where you need to go forward from there. But, we do a lot of troubleshooting. I ask a lot of questions with my students. And if they want to learn, then they want to learn. If they don't want to learn, then they don't learn. But that pretty much sums up that. Now, let me get to her next question. She also said, how to make the most out of that time. So to make the most out of that time, you need to come in with questions that you have. If you have questions regarding a certain issue or topic or whatever, bring those questions up. Ask your clinical instructor. Go look them up yourself. We also have what we call post-conference during our clinicals. And during our clinical time is when we talk about all kinds of OB-related things. I have my students bring in either articles or maybe fun facts or something they have learned about other cultures or other countries regarding OB care. We've looked up and talked about lotus births. We've talked about the farm. So if you don't know about the farm related to pregnancy, look that up. Okay, look it up and see what you think about it. It's right here in Tennessee, which is where I live. Okay, so look up the farm if you want to know more about the farm. Look up lotus birth if you want to look up more about lotus birth and what that means. So basically, look up some of these birthing practices. You'll learn a lot about those. Look up birth plan. You'll learn a lot about birth plans and what those mean and why are they good and what's the downside of having a birth plan. So during your downtime, definitely, or not downtime, to make the most of your time, have ideas and questions. Go seek, something to do. If you are required to do care plans with your concept maps, either one, then go ahead and, formulate your ideas. This is something I really drive home with my students. Formulate ideas about what you want your care plan to be on based on your patient. So if your patient's presenting with the whole time she complained was pain 10 out of 10, then what is one of probably your number one nursing diagnosis? It's going to be acute pain, okay? And you're going to say related to whatever's related to as evidenced by, whatever is as evidenced by, and, patient states pain is a 10 out of 10 and on and on and on. So be thinking about your nursing diagnoses while you're in clinical. It takes a lot of time. Be jotting those things down. Be jotting down the criteria in which you have come up with to lead you to that diagnosis. So pain was 10 out of 10. She was grimacing. She was in a bad mood. She was cursing. Whatever happens to be your subjective and objective data, whatever it happens to be, you need to make sure you be gathering that data while you're at the hospital. Also, you can't have any patient identifiers going home with you. So do not be taking pictures or screenshots or taking the whole sheet of paper with you, report sheets with you. You need to transcribe the information that you have from that sheet onto a blank piece of paper that you can take home with you with no identifiers on it, so you do not violate HIPAA and confidentiality. So be mindful of that. What else can you do during clinical time? I think that's pretty much it. Ask questions, volunteer to do things. If somebody says, hey, anybody want to start an IV? Volunteer to do it. If you get it right, wrong, or whatever, you're trying to learn how to do these things. Go do it. Anybody want to see me do a dressing change? Go do it, even if it's not your patient. Learn as much as you can learn about OB. I tell people all the time, even if OB is not your forte, which is not a lot of people's forte, that's fine. But you will see these people, these patients in all areas of nursing. How do you think they get to OB? Through the ER, so you'll see them in the ER. Sometimes our patients are so sick they don't even stay at OB. They go to ICU because something has happened to them. We've had people who've had DIC who, and look that up if you don't know what that is, who we can't keep on our unit because they are so sick, okay? They're more critical than what we can maintain on our floor. So they have to go to ICU. We've had people whose heart rate's in the 40s and we can't figure out why. So they go to med surg with telemetry on it. So they don't stay on our floor is my point. So you will see patients everywhere. We've had people whose wounds, C-section wounds, have dehisced. They have opened up. So they have home health care going out to see them and helping them change dressings and things like that. Again, home health care, OB. You never would have thought about that. You have to be mindful. Just learn whatever you can learn from that rotation and take it with you. You never know when you'll see these patients again. And then the last thing she said was, any tips for how to secure a new nurse, as a new nurse in L&D without the advantage of precepting there? So if you didn't precept in an area in which you have, in which the L&D nurse or the L&D rotation in which you did, but you didn't precept there, the best way to secure a job is just go to the recruiter or get to know the manager somehow, some way. And just simply just say that I'm interested in precepting or learning or wanting to be an L&D nurse. I will tell you, sometimes you have to go where they accept new grads. So even though you may, wherever you did do your L&D preceptorship at or L&D rotation at, maybe that's where you need to start out and get to know the manager and nurses there and work from there. That's what I recommend. I had a student of mine who she just graduated in May. No, she graduated in December actually. And she had told me during my rotation with me that she wanted to get a job, at the hospital that I work at, that she wanted to work at, which is where we did clinicals at. And she asked me would I allow her to use me as a reference. And since I worked there and she was a great student, of course, I'm like, yeah, that'd be great. And so I said, you need to go get to know the manager. And she went and got to know the manager. She told the manager that I'm done having children, that she's done having children. She's not going anywhere. She wants to work in nursery. She don't mind working nights. She basically told her everything that she, just kind of sold herself. And that's how she got the job. And as we speak, that's where she works. So she's been there since, like I said, a little after December. Took her boards in February and she's a registered nurse. So you have to sometimes go to where they're hiring, but if you cannot do that, you need to get to know the manager somehow, some way. If they have a job fair, you need to make sure you try to go to the job fair and get to know the manager or the nurse recruiter at that job fair, and just simply keep on saying you have an interest in it. And being in L&D and getting to know more about what opportunities they have in L&D for new grads. Now, if they don't hire new grads, then you won't be able to go there. But, again, that's the reason why I say make the opportunity to wherever you do your wherever you do your L&D rotation at or your OB rotation at. It may not be ideal for you to stay there long term. And that's okay. If you only stay there for about a year and move on, that's fine. But get in somewhere so you can get your experience. Once you get your experience, it's easier to move on to somewhere else than it is to, say, start fresh somewhere else. So get your experience, even if it's at the place that you did get your L&D experience at. So I'm saying they're not your preceptor. You didn't precept in that area, but you did do your L&D rotation in that hospital. That's still the time to get to know the manager. That's still the time to get to know the nurses. That's still the time to ask questions about how things go there. That's especially the time to kind of, have your eyes wide open about how they run their unit to see if it's something that you would even like. Ask the nurses questions about how, or what do you like about, working here? What do you not like about working here? Type of things. That way you can kind of go in with, with a mindset is something I can deal with. Now, mind you, nursing is not an easy profession, and you will have to go through some learning woes, okay? Some new nurse woes that's common with nursing, but you'll be fine. I guess my thing is just make sure that you ask questions and you're attuned to what you're supposed to be attuned to, and that you're doing what you need to do to be the best nurse that you can be. So I think that answered all her questions. I told her I would get her video up this week. Today I actually had clinicals myself for my own doctoral journey, and so that's why I'm dressed like this. And I just thought, since I was already dressed, that I would go ahead and make this video for her. And I think that's all she had. So if you have any questions for me regarding OB, regarding my doctoral journey, regarding just nursing in general, please leave them in the comments below, or you can email me. I'll have my email in the description box. You can also follow me on IG, and that way you can see what I do behind the scenes. It's basically my same version of YouTube, but on OB, no videos, but pictures or posts regarding nursing or my personal DNP journey. Again, like I said, I was in clinical today. Had my first day of clinical. I was pretty excited about that. But if you don't have any questions or concerns, leave them in the comments. Definitely subscribe, notification bell, like, share, comment, anything that you want to know about nursing. Again, feel free to ask. I'm still in the works of making some more videos regarding being a single parent and self-care. Someone wanted me to do a video on that. So if you want to see that video, please thumbs this video up as well, or leave a comment below that you want to see a video on how to do self-care specifically as a single parent, and how do you involve children in that? How do you handle it when you have children and trying to, maintain yourself and trying to maintain your sanity while in nursing school, or even being a nurse after the fact. So if you would like to see that, definitely thumbs this video up and leave a comment below. But until the next time, you all take care. Bye-bye.